Hello, everyone. Welcome to this month's Simon Says Expert series. I'm Dr. Jessica Parker, a gynecologic oncologist and assistant professor of obstetrics and gynecology, and I'm also a member of the Simon Cancer Center. I run the ovarian cancer clinical trials here at IU, and my research focuses on musculoskeletal health and survivorship in ovarian cancer patients. I'm really excited to talk to you guys today about both ovarian and uterine cancers. And we'll discuss both who's at risk and how patients are treated. And I have some slides to share with you. I will just apologize in advance. My 2.5-year-old got me a little bit sick, so I apologize for my voice and if I cough. And we're just going to get into the slides. So the American Cancer Society publication of cancer statistics that was published last year in 2024, you can see here that uterine cancer is now the fourth most common female malignancy. This is rapidly approaching that of colon cancer and is the fifth most lethal malignancy overall. Uterine cancer has replaced ovarian cancer as the GYN malignancy with the largest number of estimated deaths, though not by much. You can see that kind of on this bottom screen down here. And per case, ovarian cancer is still the most lethal gynecologic malignancy. So you can see through all of this that it's really important that we pay attention to these two cancers specifically, along with our other gynecologic cancers, because there are some things that we can do to help us decrease these statistics. So first of all, some basics. What is ovarian cancer? Ovarian cancer can arise from 3 different cell types in the ovary. The most common type we have is from the cells on the surface of the ovary. And scientists actually now believe that the majority of cancers that develop on the surface of the ovary are actually starting in the fallopian tube and then dropped onto the surface of the ovary or onto the peritoneum, which is the lining of the abdomen. And so that's how people who may not even have ovaries anymore may still develop an ovarian-like cancer, because we think these actually may start in the fallopian tube and sort of fall out and onto the lining of the abdomen. 70% of patients with these epithelial or cell surface cancers have advanced stage cancer when they're diagnosed, meaning either stage 3 or stage 4 disease. So that gives us a lot of opportunity for improvement in these patients. There are other cell types in the ovary. So you have the cells that help support the eggs, and you can also have the egg cells that can develop into cancers as well. And these two cell types are much more rare and tend to happen in younger women, as you'd imagine when the ovary is being used a lot for possibility of pregnancy. Germ cell cancers are from the egg cells, and sex cord stromal cancers are from the supportive cells of the egg. Occasionally, we also see cancerous tumors of the ovaries that actually originated elsewhere and then metastasize to the ovary. And these really can be from any location in the body. I've seen patients with colon cancer that have gone to the ovary, pancreatic cancer, lung cancer. Really, the ovary can serve as a place that any cancer cells that are from elsewhere can sort of go to. And that's always something that we're thinking about when we're wondering why someone has an ovarian mass. Is there something else going on beyond the ovary that we need to pay attention to? So these are the stages of ovarian cancer. You can see starting from the left, stage 1 tends to be when the tumor starts in just one or both of the ovaries. Stage 2 is when the cancer has spread outside of the ovaries, but is still within the pelvis, still down low in the abdomen. The stage 3 and stage 4, where we see 70% of our patients present, is where we see that cancer has spread to the abdominal cavity or the lymph nodes, which are the tissues that sort of run back behind all the main tissues in your abdomen and help circulate fluid in the body. Stage 4 is when you have distant metastatic disease, meaning disease that has gone elsewhere, such as in the lung or into larger tissues, such as the liver or the spleen. Overall, 5-year survival for ovarian cancer is about 50%. But as you can see, it is longer for early stage cancers, those that are stage 1 and stage 2. and certain subtypes of ovarian cancer. So our less aggressive forms can often have longer 5-year survival. However, like I talked about previously, 70% of these patients present with either a stage 3 or stage 4 disease. That means that 5-year survival for most patients is less than 33%. However, there is some hope here. I think some of this data is outdated. We have a lot of new treatments that have been developed in the past several years that are really helping drive patients to be able to live longer and live better than before. How do we treat ovarian cancer? If we have a patient who comes in with an ovarian mass and nothing else is seen, then we first start by removing this mass. So that's surgical intervention. And that can either be done with a big up and down incision or with small incisions as well. If we find that this mass is concerning for ovarian cancer, then we perform a staging procedure. And essentially what that is to assess if there's any microscopic disease or disease that can only be seen under the microscope in any other organs in the body. So what we do is we remove several other things in the abdomen to look at under the microscope. These things include the omentum, which is the thin sheet of fat that you can see that hangs off the colon, like here you see in yellow, as well as the pelvic lymph nodes and lymph nodes around the large vessel called the aorta, and you can see these in green. And we also take biopsies of the peritoneum, or the lining of the uterus. In some types of ovarian cancer, we remove the appendix. We also perform what are called pelvic washings, which is where we put some fluid down in the pelvis, remove that, and have our pathologist take a look at that to make sure there's no abnormalities and cells that are floating within the body. In certain types of cancers, like I said, we may consider removing the appendix or other organs. And depending on these results, we may decide to give chemotherapy to decrease the fact that this cancer could come back. And that would depend on where the cancer has spread already, if it's spread at all, and if there's anything else that appears abnormal within the abdomen. Most of our patients who present with ovarian cancer will treat with a combination of surgery as well as chemotherapy. The goal of our surgery is to remove all of the cancer that can be seen with the naked eye. And this sometimes requires an aggressive surgery, which means that we may have to do something like remove portions of the bowel or other organs such as the spleen in order to make sure that we remove all the cancer that can be seen. These patients would then get chemotherapy. The usual amount is 6 treatments of chemotherapy after a primary surgery. If we don't think, based on either our CT scan imaging or based on a look inside of the abdomen, that we can get everything out that we can see with the naked eye before chemotherapy, then we actually do option number 2 that you see here, which is no surgery to start, but we give 3 rounds of chemotherapy followed by surgery, and then 3 further rounds of chemotherapy. And this is to shrink the cancer so that when we go back to surgery, we can remove as much of it as possible. Sometimes after this, we also give what's called maintenance treatment, and that is where we give some people who qualify medications that can help prevent this from coming back. It's really important that we make sure that all of our colleagues understand that a gynecologic oncologist really should be involved in the treatment of ovarian cancer whenever possible, so that the patient gets the best opportunity for a surgical procedure that's aggressive and appropriate. Aggressive surgery is important and it does affect survival. This figure here shows the number of surviving patients over time, with the higher the bar on the list, meaning more patients are surviving. You can see this blue line which shows patients that had all cancer removed that can be seen with the naked eye. It's much higher than the other 2 lines. And this is why it's important that every patient with ovarian cancer sees a gynecologic oncologist for evaluation and aggressive surgery so that we can improve lifespan and survival. What about young patients with ovarian cancer? Is there an option for preservation of fertility, meaning ability to be able to have kids in the future? The answer to this is possibly. Depends on what we find. In, for example, those rare tumors that I talked about that may arise from the cells that make the eggs or the cells that support them, we would do all of the surgery that I described, but keep the uterus and the other ovary in place, as long as it appears normal. This has not actually been shown to impair outcomes and is a possibility for patients. In our more common and more aggressive epithelial or cell surface ovarian cancers, for very early stage tumors, we could also consider keeping the other ovary and uterus. If the tumor is low grade, they don't usually get chemotherapy, but we keep a very close eye on those patients. There is a risk of the tumor coming back of about 12% in that instance. In the higher grade tumors, we would still recommend chemotherapy, and survival is about the same. And there is some effect of chemotherapy on fertility rates that has to be taken into consideration. In all of my patients who strongly desire fertility preservation, I recommend that they see a reproductive endocrinologist for discussion of possibilities of treatment. And some patients are actually able to have their ovaries or their eggs harvested in order to have that ability to have a child in the future. So is there anything we can do to screen for ovarian cancer and detect it early? Unfortunately, not really. There is a long phase during which a patient does not notice something's wrong and nothing's detectable on any imaging. That imaging may include ultrasound, may include CT scan. Then there tends to be a stage where a mass is detectable, but no one's noticed it yet until it gets large enough or symptomatic enough. I always talk with my patients about the fact that women are meant to be able to carry a child, and so our bodies really are able to maintain a pregnancy that's quite large. And so in order to do that, we really don't tend to recognize masses that are small. And so it's not our fault that we don't recognize these large things until they're very large, because we're just set for that biologically. Excuse me. We have done exhaustive studies to see if there's something we can do to test for ovarian cancer early. And the things most people propose is either an ultrasound and or a CA-125 test, which is a blood test that can be elevated in women with ovarian cancer. Unfortunately, it can also be elevated due to several other things, so it's not specific. And specifically in women who have not yet gone through menopause, it's sometimes not the best test. But we often use CA-125 to help triage how worried we are, and also to follow response to chemotherapy in patients that we know have ovarian cancer. So we have a mountain to climb. There are several large trials evaluating screening in ovarian cancer. In one large trial in the United Kingdom of over 200,000 women who were average risk of ovarian cancer, who were undergoing either ultrasound, blood screening with CA-125 or both versus no screening at all, they found that the rate of diagnosis of ovarian cancer was actually the same. So it really didn't appear that in low-risk populations that we have any improvement in ability to find cancer early with ultrasound and CA-125. In a trial out of the University of Kentucky, there was also no difference in survival from ovarian cancer from those screened and those not screened. And of the patients that had screening, a third of these had false positive tests. And actually 15% of the patients that had surgery went on to get a surgical complication. So this shows us that screening has consequences and it does not change outcomes. Therefore, no professional society actually recommends screening. There are some people to which we may recommend some screening test, understanding that it may not improve survival. And then those patients are usually patients that have been genetically shown to have a high risk of developing ovarian cancer. What can you do? One of the big things is to pay attention to our body. Easier said than done. The symptoms you can see here of ovarian cancer are the same symptoms as many other things. They can include bloating, pain, difficulty eating, feeling full quickly, or needing to go to the bathroom more frequently. But again, there's plenty of benign conditions that can cause the same problem. And so it's hard to know whether this is due to something like ovarian cancer or something else. What I tend to say is that if you have symptoms such as these that are worsening, more frequent, don't go away over time and are unexplained by something else, I would think about ovarian cancer as a possibility along with other things. And I would definitely advocate to my physician that maybe we should get some testing to be sure that nothing's going on. Who gets ovarian cancer? The good thing is that in the general population of people, less than 2% of people get ovarian cancer over the course of their lifetime. So it is relatively low risk. As we all know, an ounce of prevention is worth a pound of cure. So let's think about who is at risk and what, if anything, we can do about it. So the older we get, the higher risk that we have of developing ovarian cancer. And this just goes along with any cancers in general. Most are diagnosed with ovarian cancer around the age of 70. People who have struggled with infertility or those who have not had a child or more are more at risk as well. Genetics certainly plays a role, and I'm going to focus on this a little bit more moving forward in my slides. Having a first-degree relative with ovarian cancer does increase the risk by about double, so around that 1.5% or so to about 3%, which is still low, but still doubling in risk. There's been some controversy regarding the role of obesity and talc use. We think there's a possibility these may be correlated with increased risks of ovarian cancer. And there's also some types of ovarian cancers associated with smoking. Generally, staying within an optimal weight and avoiding smoking can decrease your risk of diseases overall, and of course are recommended. So let's focus on some genetic reasons for ovarian cancer, or another way to say this is hereditary susceptibility to ovarian cancer. We know about 10 to 20 to 30% of ovarian cancers are related to genetic syndromes. You can see the largest slice of this in green is due to BRCA1. BRCA2 is next, and I'll discuss both of these further moving forward. Lynch syndrome is another genetic cause of ovarian cancer and is also related to an increased risk of both uterine and colon cancers along with ovarian cancer. And there are several other mutations that increase risk, such as PALB2, BRIP1, and RAD51C and D. These listed here encompass the majority of mutations that cause an increased risk of ovarian cancer. There are plenty of other genetic mutations that people can develop that may increase risk for other cancers, but the ones that significantly increase the risk of ovarian cancer are listed. I think this is a nice figure that helps spell it out as well a little bit for us. And it also helps us know to whom we should consider removal of the ovaries and fallopian tubes at a younger age than we otherwise might. So way over on the right of this figure, you can see that we have our BRCA1 and our BRCA2 patients who have the highest risk of development of ovarian cancer. As we go towards the left, we see two of the genes that cause the syndrome, Lynch syndrome, which are MLH1 and MSH2. And these patients all benefit from a risk-reducing removal of the tubes in the ovaries, meaning a removal of them without having any masses on the ovary that's seen. RAD51C, RAD51D, and BRIP1 are next, and we think those patients also benefit from removal of the ovaries. You can see that they have sort of an up to 15% risk of developing ovarian cancer over time. MSH6, which is next moving towards the left, also causes Lynch syndrome and is controversial because the arrows overlap this pink line, which is the threshold that we have for removal of the ovaries. But it probably is worth surgery in those patients as they get up to about a 10% risk of developing ovarian cancer. And the other mutations on the left side, there's not enough benefit to say that ovarian removal should always be done, even though the risks are higher than this blue line at the bottom, which is just the overall general population risk. And this, as you can see, the whole way to the left includes that arrow of patients with a first-degree relative of ovarian cancer. These patients do have about double the risk of ovarian cancer as the general population, and they're sort of right at that threshold for risk-reducing surgery. So this would be something that could be discussed with your physician as to whether or not removal of the tubes in the ovaries should be considered. In the next few slides, I'll break this down even further. In BRCA1 carriers, there is a high, up to 40% lifetime risk of ovarian cancer, and removal of the tubes in the ovaries is recommended by age 35 to 40. There's also some evidence that these patients have an elevated risk of high-grade uterine cancers, so a hysterectomy should be considered as well. BRCA2 patients have a lower but still up to 20% lifetime risk of ovarian cancer, and the ovaries and tubes are recommended to be removed by about age 40 to 45. In the highest risk Lynch syndrome mutations, MLH1 and MSH2, surgery is recommended also by 35 to 40. The other Lynch syndrome genes have a lower risk and are controversial. RIP1 and RAD51-CRD carriers should have their ovaries and tubes removed between age 45 to 50 years old. And as you can imagine, removal of the ovaries this early will put somebody into menopause. There are a lot of guidelines regarding whether or not someone would be a candidate for hormone replacement therapy after removal of the ovaries at an early age. I usually recommend this as long as the patient does not have any other hormonally responsive cancer that they're struggling with, so that we can prevent the problems that are associated with menopause, which include things like osteoporosis, cardiac disease, early onset dementia. So we're always weighing those risks and benefits of ovarian removal. Who should be tested for these genetic mutations? Anyone with ovarian cancer is recommended by the Society of Gynecologic Oncology to have genetic testing, any type of ovarian cancer. And this is not just to help know for family members, but also because these patients could be a candidate for additional treatment that may help decrease the risk of their cancer to come back. And in some cases, we're thinking may even increase the risk or the ability to cure a patient. If you have a family member with a known genetic mutation that I listed here, you should absolutely get tested as well. If you have a family history of cancer, if one of your first or second degree relatives have ovarian cancer, you should be tested. Or if you have a high probability of having BRCA based on the models that exist, you should be tested as well. If a high risk genetic mutation is found, you may be counseled for additional testing or early removal of the tubes and ovaries, like I discussed previously, to prevent cancer from developing. How else can we decrease our risk? Oral birth control pill use for over 5 years decreases the risk by about 30%, and this reduced risk persists for around 10 years after stopping the pill. Since we believe most of our aggressive ovarian cancers start in the fallopian tube, removal of all or a portion of the tube can reduce the risk by about 30 to 40%. Prior pregnancies and breastfeeding can lower the risk as well, with longer duration of breastfeeding leading to lower risk. Now we're going to move on to uterine cancer. Unfortunately, uterine cancer is the most common gynecologic malignancy, and rates of uterine cancer are increasing. Uterine cancer has recently surpassed ovarian cancer as having the most deaths per year. Stage 1 and stage 2 uterine cancer are when the cancer is localized, meaning it's only spread into the muscle of the uterus or into the cervix. It has not yet moved outside of the uterus itself. Stage 3 includes cancers that have gone to the tubes and ovaries, vagina, or lymph nodes. And uterine cancer is considered stage 4 if it's gone to the liver, spleen, bowel, or bladder, or lining of the abdomen or outside of the abdomen, such as to the lungs or groin lymph nodes. If uterine cancer is localized, it has excellent 5-year overall survival for the most part, especially for our low-risk types of uterine cancer, and that's around 95%. If it's spread nearby, 5-year survival is around 70%, and if it's stage 4, survival drops to about 20%. Like ovarian cancer, we have new treatments that have emerged over the past several years that we're hoping will improve these numbers. There are many ways that uterine cancer can be treated. The biggest way that we treat uterine cancer, especially in early stage disease, is with surgery. Radiation either to the vagina or to the whole pelvis is considered in patients with a high risk of recurrence or those who can't have surgery. If the cancer has spread outside of the uterus, chemotherapy and/or treatment with new technologies such as immunotherapy can be considered. And since uterine cancer often can be hormonally responsive, we give hormones sometimes in this disease. One of the big areas we consider hormone therapy is for patients who want to keep their uterus or in those who are too sick for surgery. We consider giving hormones to someone with uterine cancer who wants to have a pregnancy if they fulfill the following criteria. They must have a low-grade uterine cancer, one that's a non-aggressive type called endometrioid. These patients would need an MRI to see if there's any spread to the muscle of the uterus or outside of the uterus. And the patient needs to be well enough for hormones in pregnancy. Remember that this is not the standard of care, but rather an option that can be considered if pregnancy is highly desired. If someone wants to preserve their fertility, there are two options that can be used, either alone or together. One is the IUD, the intrauterine device, which releases hormones, and the other is an oral pill. Both have different side effects and risks. Once someone is on these therapies, it is recommended that they get biopsies of the uterus every 3 to 6 months to assess response. And if the cancer has not gone away by 12 months, or there is progression on therapy, hysterectomy is recommended at that point. Patients should know that the pregnancy rate, even after clearance of the cancer, is relatively low at about less than 50%, we think around 35%. And an additional 35% of patients do have recurrence of their cancer. It's recommended that they undergo a hysterectomy once the childbearing is complete. Patients just need to know the realities of this to understand the risks before deciding to keep their uterus in place. Who's at risk for uterine cancer? People who have never been pregnant before or those who started their period early and went through menopause late do have a higher risk. Our most common uterine cancers are mediated by hormones, specifically excess estrogen. Therefore, estrogen-only hormone replacement increases risk, as well as tamoxifen, which some people take for breast cancer. Obesity increases the risk of ovarian cancer as some of the hormones in fat turn into estrogen. Black and African American people have a higher risk of our more aggressive types of uterine cancer, and studies are being done to look into the why behind this further. Additionally, 5% of endometrial cancers or uterine cancers are due to genetic syndromes, mostly Lynch syndrome. Whenever we diagnose someone with uterine cancer, we screen them for Lynch syndrome. And if you've been diagnosed with Lynch syndrome, we often perform uterine biopsies every year until you're finished having children, at which time it's recommended to remove the uterus. Can we screen for uterine cancer? In patients who are at high risk for cancer, yes. These are our patients, just like I talked about with Lynch syndrome, who we usually perform yearly endometrial biopsies starting around the age of 30. Otherwise, the biggest thing to pay attention to is abnormal uterine bleeding, especially after menopause. Once you go through menopause, any bleeding that's coming from the vagina should be assessed by a physician because it's just not normal to have that. Now, that does not mean that there's a cancer there, but it means that it should be worked up. How might you be able to decrease your risk? Similar to ovarian cancer, oral birth control pills can decrease the risk by around 30 to 40%. Since intrauterine devices are used in fertility-sparing treatment for uterine cancer, you can also imagine they decrease the risk as well as they produce hormones. With each full-term pregnancy, uterine cancer risk decreases by about 15%. And of course, exercise and therefore maintaining a healthy weight decreases the risk as well. Obesity is a really big driver of this cancer. Overweight patients are twice as likely to develop uterine cancer, obese patients 3 times as likely, and patients with a BMI of more than 40 are 6 to 7 times more likely to develop uterine cancer. So throughout this presentation, I hope you've seen that prevention and decreasing risk of cancer is very important. Once someone's developed a cancer, we have several goals as oncologists to improve patient survival. These include enrollment in clinical trials to find new and better treatments, aggressive surgical management by trained specialists, genetic testing to see if someone qualifies for additional treatment, and finally, receiving appropriate therapy, whether that's chemotherapy, radiation, immunotherapy, targeted therapy, or hormonal therapy. Maintenance therapy is becoming used more often to prevent recurrence of cancer, and I just don't have quite enough time in this presentation to go through all of those options with you. So I've received some great pre-submitted questions, and I want to make sure that I can address as many as possible. Before we dive in, I want to invite you to ask any additional questions, and you can submit them in the comment box below or in the chat if you're joining us on Facebook. I'll do my best to cover them all before we finish up. And I'm going to start with some of our pre-submitted questions, and I'll just start from the top and work my way down. So one of the questions that was good is, has there been a notable change in diagnosis rate or cancer risk for women with benign conditions, such as ovarian cysts, polycystic ovarian syndrome or PCOS, or endometriosis? So simple appearing ovarian cysts, even if they're multiple and numerous, do not increase the risk of ovarian cancer. Any complex cysts should be evaluated for possibility of an abnormality developing there. As far as PCOS, there actually has been shown to be an increased risk of uterine cancer in patients with PCOS. And in endometriosis, there is a small but increased risk of development of certain types of ovarian cancers, and those usually include endometrioid type and clear cell types, which are more of our rare types of cancers. Another question was how breast cancer patients pay special attention to the disease for early diagnosis and any biomarkers. You know, I'm not a breast oncologist, so I would reserve answering that question to one of the breast oncology teams. I do know that there is a specific biomarker for breast cancer that can be looked at, but I do not know the specifics, so I would defer to a breast oncologist who specializes in that area. Is there a risk with family history of ovarian uterine cancers? I think we covered that there is a risk that's increased. At what age should women begin screening for GYN cancers? Are Pap smears the only or most reliable test? So this is a great question. And I think I covered screening for ovarian and uterine cancers in my talk. As far as other gynecologic cancers, including cervical, vaginal, and vulvar cancers, which is the outside of the vagina, the Pap test is really the best thing we have to screen for cervical cancer, and that should be started at age 21. There's no recommendation to start that early, and actually we're moving more towards assessment of risk using high-risk HPV, which is a virus that can cause cervical cancer. And so please discuss with your gynecologist about this. Usually Pap screening is continued until about age 65, as long as normal Pap smears have occurred. If not, then that needs to be extended further. There is no good screening for vulvar cancer except having someone look. And so I recommend that everyone go to their gynecologist as scheduled for their pelvic exams. Who should get a baseline CA-125 test? I believe I went over screening for using CA-125 and the unfortunate fact that this and routine pelvic ultrasound is just not recommended in patients that are overall low risk. In patients with a family history, then that should be a discussion that's had. Still, even with a family history, unfortunately, screening is not super effective, and so that needs to be taken into consideration. Another question that we have in the chat is, someone had their uterus removed, but the ovaries can't be found on a scan. Any idea why not? That's a great question. I don't know how old this person is. Once someone gets past menopause, the ovaries shrink down quite a bit to about 0.5 centimeter to 1 centimeter. Can sometimes be a little bit bigger, but usually around that size. And so often the bowel sort of overlies those ovaries, and even on ultrasound, they can't be well seen. That's actually a good thing. If your ovaries can't be seen on scan, that means there's unlikely to be any masses there. As far as a question regarding Cowden syndrome, so Cowden syndrome has been shown to be associated with multiple other cancer types, but has not been shown to have an increased risk of ovarian or uterine cancers. Of course, I would always take into consideration the other things to think about when it comes to paying attention to your body for those types of risks. What is the youngest age to date diagnosed with ovarian or uterine cancer? I don't know the answer to this. It's a good question. Anecdotally, in my practice, uterine cancer diagnoses are getting younger and younger. Unfortunately, as the obesity pandemic is increasing, I've seen patients in their 20s, unfortunately, with uterine cancer. I've also seen patients as early as their teens with ovarian cancer. Those are usually are rarer types of ovarian cancer, like your germ cell tumors or the sex cord stromal tumors. So it's something to be thinking about sort of at all ages. Someone submitted a question about understanding additional insights and perspective on cervical cancer, having a dear friend diagnosed with uterine cervical cancer. I'm so sorry to hear that. That's really tough, and it's hard to know how to support someone through that. Cervical cancer is a rare diagnosis, but one that is tough to deal with, and is treated quite differently from uterine and ovarian cancers. Cervical cancer is pretty rarely treated with surgery. It's more frequently treated with chemotherapy, radiation, or a combination of both things. And it can be tough. How do you address fertility preservation with these patients, and do they have time to pursue egg banking? I believe I addressed that a little bit. As far as egg banking, often reproductive endocrinologists can actually do sort of a stimulation cycle to get eggs pretty rapidly. It takes about 2 weeks or so. So I do, if someone is very, very strongly feels that they would like to pursue that, I am aligned and supportive. I think the controversy and problems come in when you have 2 ovaries that appear abnormal. And do you think you're going to get normal tissue from that? That can be tough to discuss and come up with a good plan. How is uterine cancer uniquely different from cervical cancer? So there are specific things that are seen under the microscope in patients with uterine and cervical cancers that help the pathologists differentiate between the two. Cervical cancer is 95% of the time associated with HPV infection or human papillomavirus infection. And that is different from uterine cancer. Uterine cancer is more associated with hormonal changes. Excuse my voice. Are either of these associated with an increase or reduction in risk? And the question is about childbirth and use of hormonal birth control affecting risk factors for ovarian cancer. And I went through that in my talk. Another question that we recently got is how should chemotherapy and immunotherapy be interlaced for uterine and ovarian cancers? So immunotherapy we are using much more frequently now in uterine cancer. It's been shown to be effective in a lot of patients with uterine cancers. Ovarian cancer is a challenge. We know that there's something about the immune environment in ovarian cancer that's important. But generally, ovarian cancer is more of what's called a cold tumor, where it's not as responsive to the immune system because for some reason or another, the ovarian tumors tend to somehow kind of tamp that immune system down. So we're doing a lot of testing about, are there ways we can combine immunotherapy with certain chemotherapies or maintenance therapies that we have already in order to find patients with ovarian cancer that would benefit. We're just not there yet. So we're not using immunotherapy very frequently in ovarian cancer. Okay. I have a friend whose CA-125 bumped up slightly. She's not had an oophorectomy. She's 72, and she gets routine vaginal ultrasounds and breast MRIs and mammograms. How concerning is it, and what else could cause a bump in the CA-125? So CA-125 can be elevated in patients with liver dysfunction, so cirrhosis. It can be elevated with generally any inflammation in the abdomen at all. And so it's really non-specific. I'm assuming since this patient's BRCA positive, I would have recommended that this patient have her ovaries removed many years ago. And if I was seeing this patient, would consider removal of her ovaries at this point. We know that even in patients we're taking out ovaries around age 35 to 45 for BRCA, that there's about a 5% risk that we might find an ovarian cancer that we weren't expecting, even with normal ultrasounds or normal scans. So this would be somebody who, unless she has other reasons not to have her ovaries out, I would consider removal of the ovaries at this time. I don't see any other additional questions submitted. Thank you everyone so much for for joining me for this month, Simon Says, and working through my illness. You can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. Thanks, everybody.